Hello, professionals. This is Dr. Saad, and as you know, we are recording a series of lectures for pharmacists who are going to appear for international equivalency exam. So today's our topic under the central nervous system is the epilepsy. Just for a brief introduction of epilepsy, as you know that it's an unpredictable discharge of seizures, and you can say it is an abnormal electrical synchronized impulses discharge which alters our sensory and motor nerve transmissions, which ultimately affect on our behavior as well as conscious, and it actually alters these our behavior and conscious. This is a simple introduction of epilepsy, and there are various types of epilepsy like tonic-clonic seizures, like absence seizures, like you can say Jacksonian, like is known as Jacksonian's epilepsy, and similarly many types of epilepsy. So we will discuss as we will move on our topic, but major focus would be on all those points which can be a part of exam. So let's start our point number one about anti-epileptic drugs. Uh, it's a point that anti-epileptic drugs can be used for an acute condition. For example, even when there is no epilepsy, these drugs can also be the part of prescription. Like for the meningitis, it can be used for the earlier period followed by the neurosurgery. It can be part of that medicine, as well as when there is a chances of brain injury. Anti-epileptic drugs can be the part of prescription even in that case. And point number two is about our first drug, that is the phenytoin. It is a very drug of choice for the management of epilepsy, and it's an anticonvulsant, belongs to anticonvulsant drug. It actually alters the action potential, specifically at feedback mode. So its dose is for adults. Its loading dose is 15 mg to 20 mg per kg per day, and its actual dose is 300 mg per day. Either it can be given in one single dose or it can be divided into three dose DDS form. So it has a very narrow therapeutic window. So its therapeutic drug monitoring level is required. So you know that almost majority of anti-epileptic drugs require serum plasma level monitoring because of their adverse effect profiles. As I will tell you about this phenytoin. Phenytoin also have adverse effect profile because and its dose modification is required if ADRs appears, and definitely there is required for its dose reduction. There are some common ADRs relevant to this phenytoin. Is the it's actually ataxia. It happens when patient lose its coordination and balance. Similarly, other skin-related ADRs, that is the hirsutism and Steven Johnson syndrome and nystagmus, as well as gingival hyperplasia, as well as mor- morbilliform rashes, and also side by side there is the issue relevant to skeletal system, that is the osteomalacia. These are the common adverse effects relevant to the phenytoin use, so its therapeutic dose monitoring is required. So this was all about this point number two relevant to phenytoin. It's an anticonvulsant drug. So let's move on to our point number three, that is about the vigabatrin. Vigabatrin is a drug. It also belongs to anticonvulsant drugs. Actually, as we talked about in a sedative and hypnotics drugs when we recorded in that video that it actually cools down the brain and stay away our body from the stress, because GABA is an inhibitory neurotransmitter. Actually, in epilepsy situation, GABA transmission drops. So we use some drugs like this vigabatrin to enhance the level of GABA to maintain the patient and to avoid the patient to fall into the epilepsy. It's this vigabatrin, its dose in the babies, it's actually play a key role, and its mode of action is to irreversibly inhibit the GABA transminase. Because of that, level of GABA increase, gamma aminobutyric acid level increase, and patient is cured by this improved level. So its dose in babies is from 50 to 150 mg per kg per day, and for adults its dose is 500 mg two times per day, and it can be from 2 to 3 gram per day. This is the its dose ranges in adults as well as in babies, and it has an interaction that is it's induce this actually the bagatrin. It induces enzyme and increase the clearance of certain drug, that is the phenytoin, carbamazepine, and phenobarbital. Phenobarbital belongs to the class of barbiturates. Carbamazepine and phenytoin belong to class of, that is the anticonvulsants. Just for a reminder, I would like to mention dose again. For as you know, the phenytoin dose is 300 mg once per day or TDS per day. Similarly, carbamazepine, its dose in the children is 15 to 20 mg per kg per day, as well as for adults its dose range is from 800 to 1200 mg per day. Maximum dose can be from 1600 mg per day, and even in rare cases carbamazepine dose can be 2400 mg per day. As you know, over long use, this is a self-inducive drug, so its use should be kept in a very cautious way. So this is all about the carbamazepine, and lastly about the phenobarbital. It's a barbiturates. Its dose is 60 to 200 mg BD or TDS. So just it was a brief review of doses of these drugs, and these drugs are being you can say there's an interaction between between the vibactrin because it induces the enzyme and increases the clearance of phenytoin, carbamazepine, and phenobarbital. So this was all about point number three. Now, point number four is about the valproic acid. Valproic acid is an also anticonvulsant drug, and its initial dose is 15 mg per kg to 60 mg per kg, and it is used for tonic-clonic seizures, which is also known as grand mal seizures. And point number five is about the treatment of epilepsy. Just there's a simple introduction, that is you can also use the diazepam, benzodiazepam. Its dose is 1 to 2 mg per OD or BD. Diazepam and succinylcholine, as we discussed about it when we were dealing with the autonomic nervous system. We discussed this drug with the name of suxamethonium. It's also a short-acting neuromuscular blocker, which is also used in the treatment of epilepsy. Side by side, there's a phenobarbital, as I told you right now. About its dose is from 60 to 200 mg or BD or TDS. And similarly, these are the drugs which is part of the prescription of epilepsy, but not phenothiazine. Phenothiazine is an used in the treatment of schizophrenia, so it is not part of the anti-epilepsy drug. Point number six is about the trigeminal neuralgia. It's actually a sudden attack of severe pain at the fifth cranial nerve, and it is being specifically treated with the carbamazepine. And carbamazepine, side by side, we use intraganglionic injection as well as a vitamin B12 for the management of this trigeminal neuralgia, because it is severe attack of pain at fifth cranial nerve, that is in the facial area. This is also defined as known as the trigeminal neuralgia. So carbamazepine is one of the important drug for its management. Point number seven is about the metabolism of folic acid altered by the altered patient taking anticonvulsants. This is that the person who is using folic acid and side by side anticonvulsant, there can be an interaction that metabolism of folic acid is being altered by the anticonvulsants. As you know, anticonvulsant drug examples are the basically phenytoin and carbamazepine and valproic acids. These are the example of anticonvulsant drugs. Point number eight is about again the narrow therapeutic index of phenytoin, as we have already discussed this point, that you need to monitor serum plasma level of phenytoin. Point number nine is about the generalized absence seizure, and it ethosuximide. It's a first line treatment for generalized absence seizure, and its dose is 15 to 40 mg per kg, and for elders its dose is 250 to 1500 mg per kg. So this drug that is known as ethosuximide, it is specifically used for generalized absence seizure. It's as a part of first line of agent for its treatment. But phenytoin, diazepam, valproic acid, phenobarbital, as I have already told you, its previous points, its doses. These all are used for grand mal seizures, but ethosuxamide don't use in the grand mal, or in other word you can say for tonic-clonic seizures. Phenytoin, diazepam, valproic acid, and phenobarbital are used, but ethosuxamide isn't used for this indication. It is specifically used for generalized absence seizure. This was so. Next point is point number 10. That is about again about the phenytoin. Phenytoin causes gastric irritation, so it should be taken with the food. This is point number 10. So point number 11 is about another interaction, that is the once you are using anticonvulsant drugs side by side, you are adding diphenhydramine plus anticoagulants. These two combination, diphenhydramine and anticoagulants, will increase the anticonvulsant toxicity, so this combination should be avoided. Point number 12 is about the Jacksonian epilepsy. This is a type of epilepsy which begin with one group of muscle and progress to adjacent group. In the This is a specific specification of this type of Jacksonian this type of seizures, that it begins with one group of muscle and progress into the adjacent group of muscles. In this, it involves sensory motor and specifically autonomic nervous system under the transmission controlled, or you can say smooth muscle controlled under the autonomic nervous system. Mostly, it can also involve in abnormal seizure activity of these muscles. So this is also known as Jacksonian epilepsy. And focal conversion during its consciousness is also part of this condition. So you just must search for this Jacksonian seizures and see its video. You will get its idea that how it works and how this situation looks like. Point number 13 is about again the repetition of previous point, that is that I have already told you about the GABA receptors. As you know that we use vigabatrin that irreversibly inhibits the GABA transmission transminase, which actually increase the level of GABA. Similarly, Tgab, Tgabin, this is another example of GABA increasing GABA transmission increasing drugs, that is, and it works by GABA 1 gate 1 GABA transporter inhibitor. So these two drugs, vigabatrin as well as Tgabin, these two drugs play a key role in increasing the level of gamma aminobutyric acid, which is an inhibitory neurotransmitter. It has two subtype A and B, as we have discussed. It also play a key role in the treatment of epilepsy. Point number 14 is about again about the grand mal epilepsy, that is also known as generalized tonic-clonic seizure, and it is in its treatment strategies. So as you know that grand mal seizure is about treated by valproic acid, phenobarbital, and primadone, and also phenytoin. Phenytoin. These are the four drugs which play a key role in the management of tonic-clonic seizure, generalized tonic-clonic seizures. And valproic acid, as just for the reminder, as we have mentioned, its dose, phenobarbital, its dose is from 60 to 200 mg per day, as well as primadone, its dose is 10 to 20 mg per kg per day, and diphenyl hydronation, it's also the name of the phenytoin. As I told you, its dose is 300 mg per day, single or TDS dose. And these all drugs are the part of prescription for the management of tonic-clonic seizure. Next is the Pettyman epilepsy. It is treated with the use of drug, that is the ethosuxamide, clorazepam, and ethosuxamide, as I have already told you, its dose, that is the 15 to 40 mg per kg, and 252 for elders, 250 to 1500 mg per kg. Similarly, clorazepam, its dose is 0.5 mg to 1 mg per kg per day. And trimethadone, no, this drug is rarely used, but it is also mentioned in the list of management of Pettyman's epilepsy. Similarly, sodium valproate, These are the drug which is used for the management of pediment epilepsy. So I want to share another point under this 14 point, that is the grand mal's, about the relevant to grand mal seizure. Our major strategy is to use the benzodiazepine, whose example is diazepam, to stop the seizure. First of all, we will stop the seizure. Then we will use phenytoin, that is the anticonvulsant, to manage the situation in a long term, because phenytoin is a drug of choice to maintain the seizure. So this was about point number 14. So let's see the point number 15. This is about an electroencephalography. It is a technique through which we monitor or detect epilepsy in a patient and monitor. This is an actually diagnostic technique for the detection of epilepsy. This is known as the electroencephalogram. Electroencephalogram, exactly, electroencephalogram. Point number 15 is about the status epilepticus. Status epilepticus. Its drug of choice is diazepam, and more than one seizure, and its specification is it is a more than one seizure in 5 minutes. This is if a seizure appears like this, when more there happen a more than one seizure between the period of 5 minutes, then it will define as a status epilepticus, and its drug of choice is diazepam. As I told you that we will use benzodiazepine for stopping the seizure, and then we will maintain it with the anti-epileptic drugs. So point number 17 is about the trigeminal neuralgia. As we have discussed, it's a repetition of previous point, that carbamazepine is drug of choice, and it is actually maintained by the vitamin B, vitamin B12, 1 mg, and injection of alcohol into the ganglia for the management of trigeminal neuralgia. Point number 18 is about the phenytoin. Its brand name is dilantine plus phenobarbital. If you use these two drugs in combination, dilantine, which is question can be like this. They can also mention the brand name of one drug, like it has mentioned here, dilantine plus phenobarbital. Once you use it two in a combination, then the level of dilantine, like the level of phenobarbital, drops. So like it will act as an interaction. The phenobarbital play a role in dropping the level of phenytoin. Once you will use these two drugs, like barbiturates as well as anticonvulsant in a combination. So be careful while writing a prescription. Point number 19 is about colorazepam, chlorpromazine side effect. Its side effect is photosensitivity. It's a conventional antipsychotic drugs. Point number 20 is about the carbamazepine. Its long-term use induce its own metabolite. As I have already told you, that once you use a carbamazepine, just for your reminder, as I told you, its doses is from 800 mg to 2400 mg. That is, although 2400 mg dose rarely used, but it is mentioned in book for the management. But if you use it a long term, it will induce its own metabolites, and its indication is again repetition, that is the trigeminal neuralgia. Point number 21 is about the barbiturates. Question is about its pregnancy category. It's fall under the pregnancy category D. Point number 22 is about the absence seizure. Absence seizure and its treatment. It's a repetition of the previous point. As I told you, that ethosuxamide, it is a drug of first line of choice for the management of absence seizure. Point 23 is about the loading dose of the phenytoin. Phenytoin, as I told you, that 15 to 20 mg per kg for status epilepticus. For simple epilepsy, phenytoin dose is 4 to 5 mg per kg. But simple, keep it in your mind that 300 mg per day maximum dose. 300 mg per day. Either you give it in once or divide in 3 times, or you reduce dose. It depends upon the patient response and clinical situation. Point number 24 is about the trigger of seizures. As there are some triggers like lack of sleep, like stress, alcohol, and menstruation. These are some of the triggers points for the seizures, and it can be a part. It can play a key role for the emission of impulses, or synchronized impulses, which ultimately appear in the form of epilepsy. Point number 25 is about the neural tube defect. There are some drugs like valproic acid, like phenytoin, like carbamazepine. As I have already tell you about its doses, I have already told you about the doses of this drug. So I think so there is no need of repetition again. These drugs shouldn't be used in pregnancy because it causes neuronal tube defect. Point number 26 is about the clonazepam and hyperclonazepam. It's an interaction with the diabetic patient because it causes hyperglycemia. So, if a patient is diabetic and side by side suffering from seizure, be careful while using this medicine because it can cause hyperglycemia. Point number 27 is about the epilepsy and drop of GABA. Exactly, there's a relation of epilepsy and drop of GABA. Once the person is suffering from epilepsy, you will monitor a drop of gamma aminobutyric acid level. That's why we use other drugs, that is the vigabatrin as well as tigabin. These drugs for the increasing the level of GABA to treat the patient. So point number our 28 point is about the carbamazepine and hyponatremia. Carbamazepine causes hyponatremia. So here you need to review our previous video relevant in which we tell about we told you about the you can say the lithium carbamazepine as well as valproic acid for the management of bipolar disorder. But we tell you about that whenever you are using lithium carbonate, then adequate level of sodium in the body is required for which will play a key role for the clearance of lithium. Otherwise, there will be a side effect. One of them side effects was diabetes. You can say one of the side effects was convulsion and diabetes insipidus, like in which we use vasopressin for its management. I think you just get a flash of this. Just listen to our previous video, you will get about it. So carbamazepine causes hyponatremia. So be careful while using carbamazepine in the combination with lithium as well as valproic acid because whatever it may be, we have to maintain the adequate supply of sodium to avoid the side effect relevant to lithium in the management of bipolar disorder. And this point is again indicating it here. Point number 29 is about the which decreases the seizure threshold or anti-epileptic drugs decreases the seizure threshold. So I think the video is going too long. So the remaining part will be uploaded into the next video. Thank you so much, professionals. And if you feel that this effort is helpful for you, then please subscribe my channel and